não vai dar. Então, bom dia a todos, bem-vindos a mais uma apresentação do Four Valves. Hoje uma situação muito especial, temos um convidado estrangeiro, o Pablo vai fazer as apresentações, e um assunto muito interessante, que é o link paravalvar, e o anúncio também do futuro, é um grande progresso, um grande passo para o nosso querido Four Valves, que é de todos vocês, e é para apresentar, aprender, mostrar e fazer. O Pablo continua a apresentação dos convidados e damos um ótimo trabalho. Obrigado.
Okay, Max, thank you very much. Good morning, everyone. This is Pablo Tomé from Piracicaba, São Paulo, Brazil. It's a great pleasure here because we have a special session on PVL, mitral PVL with the Occlutech device that's recently came to Brazil some months ago. So we are starting our experience, and we have a special guest from the UK, which is Professor Iqbal Malik from Hammersmith Hospital, who was really kind to be here on a Saturday morning or afternoon in UK. So thanks for that. And we have a lots of Brazilian specialists here who are going to be with us. They are Marcelo Miglioranza from Porto Alegre, Brazil. We have Carlos Vinícius Abreu from Salvador, and Ricardo Wang from Belo Horizonte. So we have lots of good guys, good people from all the corners of Brazil and also from the UK. So first of all, I would like to ask Pedro and Tuca to play a video. We are very happy to show this video here because it's the beginning of a collaboration project between CSI and Four Valves. So we want to spread the information to all Latin American colleagues so we can learn from the best. And I think this will be paramount for us, this achievement. So Pedro, please, can you play the video for us?
Hello and welcome to all our friends in Latin America. My name is Shak Qureshi, and you can also see Horst Sievert. We're the co-directors of CSI. In South America, you have been running webinars for educational purposes. We've been doing webinars from CSI over the last 4 or 5 years since the COVID epidemic, and these are all available for everybody to view and learn from. And now there is a proposal from Pablo Tomé for us to collaborate between CSI and Four Valves group in South America. And I think this would be an excellent idea. We would really want to spread the education. And for that to be promoted, I'll just ask Horst to say a few words as well.
Yeah, I think this is really a great way to collaborate, and we invite all of you to come to CSI Frankfurt in June 19 this year, and also to our other conferences in Asia and America, in Japan. And when I think about how CSI evolved over the last 2 decades, actually the only continent besides Antarctica we have not been organizing conferences in South America. So next year we may organize something in your environment. So anyway, hope to see all of you at CSI Frankfurt, at least, if not in the other locations as well.
Okay, so that's it. Let's get started. We are very motivated with this collaboration project, and let's get moving and learning from the best. So I'm gonna start with my friend Marcelo Miglioranza from Porto Alegre. He's the coordinator of the ECHO program on interventional ECHO at Hospital Mãe de Deus. He's gonna make an introduction about the paravalvular leak and strategies for better approach. Thank you, Marcelo, for being here.
Thank you very much, Pablo. It's a great pleasure to be with you all here to talk about a very nice and important topic that is a paravalvular leak. So in this next 15 minutes, we talk about how to evaluate by echo the paravalvular leak. So I will go on in Portuguese for our audience. Então, pessoal, nesses próximos minutos vamos falar a respeito do fechamento de leak periprotético, dicas e estratégias para uma melhor abordagem. O refluxo paravalvular é uma complicação relativamente comum. Claro que com o advento de próteses cada vez melhores e com a melhora da técnica cirúrgica e técnica de intervenção percutânea, então tanto o implante percutâneo quanto o implante cirúrgico de prótese estão tendo resultados cada vez melhores. E a incidência de leak periprótese tende a diminuir. Claro que ela é uma complicação que se faz principalmente naqueles pacientes que têm múltiplas intervenções e múltiplas substituições cirúrgicas periprotéticas. Então, ele pode ocorrer tanto em troca valvar, tanto em reparo valvar, quanto em implante valvar percutâneo. E durante o período interoperatório, então, em série de casos que avaliaram logo após a saída de circulação extracorpórea, a incidência ela pode ocorrer em até 20% dos casos, mas normalmente são leaks insignificantes do ponto de vista hemodinâmico e tem curso benigno. Quando a gente pega uma coorte geral de pacientes, avaliando também no segmento de longo prazo, a incidência geral ela também fica em torno de 7% a 22%. Agora, aqueles pacientes com leak periprótese, muitos deles, 85%, podem vir a cursar com clínica de insuficiência cardíaca, né? 13% a 47% com hemólise e, não desprezível, muitos desses pacientes têm um risco de endocardite. Então, aqui que se mostra qual que é realmente a importância de avaliar o leak adequadamente e de tratar ele, para mudar o curso
Marcelo,
do paciente.
Marcelo, desculpa interromper você, mas a gente vai ter tradução depois com legendas no site. Você se incomodaria em falar em inglês para todos entenderem?
Okay, I will try to to go on in English. I don't know if I will have enough vocabulary to go on, but let's try. I think it's very important due to this collaboration between CSI and 4Valves.
Thank you very much.
Okay, so we are talking that perivalvular leak is a very common complication that it could appear also in valvular repair, percutaneous implantment, and implant of surgical valve. And during the intraoperatorial period with intraoperatorial echocardiography, we could realize that it's a very common complication with an incidence about 5 to 20%, but most of these cases are benign with very small leak that does not have hemodynamic implications. But when we look at these patients in a cohort and follow up with several years, we see that this incident does not change so much. And the general incidence is about 7 to 22%. But during the long-term follow-up, most of these patients with leak could develop heart failure, hemolysis, and of course, they have a higher risk of endocarditis. This study, it's a little bit old, but it's very good because it's a retrospective cohort of more than 1,700 patients that have gone to mitral or aortic valve replacement, and they follow about 10 years. And this study demonstrates to us that most common paravalvular leaks and the most severe ones are related to the mitral valve prosthesis. And this is interesting to see that the incidence during the intraoperative or discharge, it's relatively small, but most of these patients that have severe leakage, they develop it on the follow-up. And this is corroborated with this another study published on Journal of Thoracic Cardiovascular Surgery in 2015 that demonstrate that not just in mitral valve replacement, but also in aortic valve replacement, during the follow-up is very common to develop this leakage. And this moderate to severe leakage usually appear during the long-term follow-up. And this is interesting to understand this difference between the intraoperative leakage that usually it's non-significant in terms of hemodynamics, and also when we follow up these patients, they usually does not have a different survival curve in comparison with the patients without paravalvular leakage. However, these patients who develop the paravalvular leak in the follow-up, that usually is moderate to severe, yes, have a different survival. And these patients is mostly the focus of our intervention to repair this leak. So this clinical trial, it's also very interesting in this statement that try to explain why there is patients that develop leaks in the long terms. And most of the contributing factors are annular calcifications, tissue fibrillity, prior endocarditis. So most of these patients is the ones that have gone to multiple valvular replacements or have tissue fibrillity due to private endocarditis. And also the type of the surgical technique, it's related with development of the leakage. When we look to aortic valve replacement, this statement demonstrates that the most common is the appearance in non-coronary cuspid. However, in my particular experience, most of these cases that we evaluate for leakage closure are related to the left coronary cuspid. My experience is a little bit different, but this is a huge amount of studies they evaluated, so the epidemiology, yes, could be different. And it's interesting also that in aortic valve replacement, it's less frequent than mitral. And this is related with the technique, related with the flow direction and how the prosthesis is placed in the aortic valve annulus. So this supraannular position and the sutures could be an issue to the appearance of a leakage. In mitral valve replacement, most of these leakages are related to anterolateral position, posteromedial positions. And the posteromedial position is explained by the proximity of the circumflex coronary artery to this region. So most of the surgeons do not perform a deep suture, and a very this alternance of the suture could be related with the appearance, and the appearance could be late in 26% of the cases, and in the first years in 74% of the cases. So This is what we have also commented before, the risk factors for the perivalvularity. When we go to the diagnosis and quantification, we know that the clinical exam is have no accuracy to determine. Usually, the clinician could detect a murmur, but most of the liquids does not show murmur. So the echocardiography evaluation, it's the main technique to identify. And we use the same principles of mitral regurgitation, native mitral regurgitation quantification, despite being not validated, and also for the aortic valve regurgitation. The most regurgitant jets are eccentric, so they are very tough to diagnose, very quick, because usually in transthoracic echo we have the shadow of the prosthesis or the prosthesis annulus, and we need to perform non-usual projections, and also have a high suspicion to go on and this diagnosis, like a discrepancy between the maximum and the median gradients, and also the clinic of the patients, the size of the chambers. And the CT and CMR are good techniques to confirm and also perform a complementary evaluation. But a good TOE could be enough to diagnose and quantificate this technique. And why quantificated liquid? Because they are related with prognosis and with the symptomatology of this patient, and also with the ventricular dysfunction and the mortality of these patients. At the beginning, we used it to quantify this liquid using the vena contracta width and the jet length. But you know that this it's not so precise. And nowadays, with the advance of the 3D echo, we started to perform the vena contracta area. And so this is the effective orifice, regurgitant orifice area, and also the dropout from area that is related with the anatomic regurgitant orifice. This is the same, not just for the mitral, but also to the aortic perivalvular leak. At the beginning, the first statements recommended us to evaluate the circumference of the jet that would be related with the severity. And that is true in most of the cases. But in some cases, we could have a jet that does not achieve a significant percentage of the circumference, but they have this very this is a large jet in the different direction. So this jet have a higher regurgitant orifice and a higher regurgitant volume. And that's why that some studies correlating with CMR demonstrate that the echo would be imprecise in determining the severity of perivalvular aortic leak using this technique. And with the 3D echo, so we could realize if there is a single or multiple leakage. We can see the morphology and the extension, and perform these more precise measurements that are the effective regurgitant orifice through the vena contracta area, and also the anatomic regurgitant orifice, measuring just the dropout area. And we can demonstrate this in a 3D image from a perivalvular aortic leak. This is after a TAVI implantment. This was a core valve implantment. And in a longitudinal image, we can see this liquid in a posterior position. And when we turn to in-face image, we could see that this leakage would have approximately 20-25% of the circumference. However, when we crop this image and go to the orifice, the really orifice, regurgitant orifice, we could realize that this orifice is quite smaller. And why we have this discrepancy in image? Because most of these leakage does not have a direct flow. They have a serpentinal flow. And this is very tricky to get the image into the plane. So most of the cases, and it's recommended to obtain a 3D volume data set, and then with a multi-slice reconstruction, we could align the jet and measure the true regurgitant orifice.
Marcelo,
yes.
Marcelo, please, you have 3 minutes, okay?
Yeah, okay. So going on, this demonstrates how 3D error it's more accurate to quantify, and this is the CMR study correlating with the percentage of circumference demonstrating the inaccuracy of this method. Okay, so when we should recommend this patient for a perivalvular leakage closure, we have absolute indications when we have hemolysis, symptoms of heart failure, mild or moderate perivalvular leakage with decline of left ventricular ejection fraction, or progressive left ventricular enlargement. And the relative indications is the risk of endocarditis, asymptomatic patients, even of conventional replacement or TAVI. When we perform, we have two options of to treat this perivalvular leak. The surgery ones, we know that most of the, until nowadays, they say that is the election treatment, but we have a higher mortality, higher than 16%. But okay, we have a good survival curve in these patients that survive the surgery. The percutaneous is an alternative with a low risk. In partly, we are using in these high-risk patients. It's for here in Latin America a recent technique and less invasive, and is recommended even in the centers with low experience. The pre-procedure evaluation needs to exclude the presence of thrombus. We assess the number and dimensions of the leaks and the location of the leaks. And the location, we usually use this in mitral valve, the surgeon view, considering the aortic valve as a reference for the 12R. And then we use this method of R's in a clock to locate it. And just to note that the fluoroscopy image is inverted with the echo image. Here, as example, we have a huge perivalvular leak located about 10 to 11 R. Here, to correlate the echo and the fluoroscopy image, demonstrated that they are mirrored. And the different techniques we could use to assess the perivalvular mitral leakage. We could use a retrograde one or anterograde one, cross through
Marcelo,
but it's not the focus of my
2 minutes.
Okay,
2 minutes,
yeah,
Marcelo.
I'm almost finishing, because then that's the case. Okay, and use it to use not dedicated devices, but now we have a new device in the Brazilian market that is dedicated for the perivalvular liquid closure. And this is a case of a female patient with multiple cardiac surgeries, 3 previous mitral and aortic valve replacements with hemolysis and heart failure, and a huge perivalvular leak. This patient, we have gone to apical access to close this leak. And you can see here the image of crossing the leakage. And then with the image of echo, seeing that we have properly crossed, and then implanting the device and closing the leakage here. And this is the final result, that we have a successful closure of the mitral valve perivalvular leak. So in this case, we implanted 2 devices. So the complications of the perivalvular closure percutaneous is urgent cardiac surgery in at 2% of the cases, death in 2%, complications assess, embolization of the dispositivo, the prosthesis impingement due to the device, and prolonged time of fluoroscopy. So
Marcelo, I'm really.
I finished it, Pablo.
I have to ask you to stop, because otherwise we cannot exchange ideas with Professor Iqbal. Okay.
Thank you very much.
Because he has to.
Slide, Pablo. This okay. Thank you very much.
Okay, Marcelo. Thank you very much. Sorry for that, because we were really out of time. So I kindly ask for Professor Iqbal to make some question for the echo guy. What do you think of it? If you rely only on echo in your center, sorry, or if you have other diagnostic approaches for your cases.
Thank you for the invitation. Thank you for the invitation. And sadly, I can't speak any Portuguese, so I'm very impressed by giving talks in a completely different language. So well done to Marcelo. So transesophageal echo, I think, is the standard. For some leaks, the transthoracic will be better than the transesophageal because of shadowing. And so I think it's a combination of those 2 images that gives the answer about whether there is a leak or not and how big it is. I use CT to plan the procedure. It makes the cath lab procedure so much easier when you've got your angle of attack already sorted out. And we do not have co-registration in our cath lab. It might be quite useful, but I've managed to survive years without it. It's a lovely tool to have. And for the paravalve leak, it's probably the only procedure where I think it would probably add benefit compared to the standard things that we do. So I completely agree with almost everything that Marcelo has said, that it's a great guide to the procedure. I'll make a comment which I made in my talk to say that if you've got an aortic paravalvular leak, don't have a go at your echo guy in the cath lab, because it's very difficult to image the aortic valve leaks. It's often a transgastric view which shows the leak. You can't direct very easily. But if you're doing a mitral paravalvular leak, then demand the best from your echo person, because the echo imaging is beautiful for mitrals. It shows you exactly where you need to go, and most of the procedure can be guided by that. So I think it's a team approach, and having an absolutely fantastic echo person in the room when you're doing your intervention changes it from being blind to seeing again.
Thank you very much. Wang, do you have lots of experience? And I know you. What's your opinion about this? You work with echo only or CT? What's your? Sorry about.
Good morning to everyone. I think it's I agree with Dr. Malik. I think it's a CT. It's important for as intervention to plan how to attack the leak. and plan about how many plugs we have to use in this case. But I will ask Professor Malik and Marcelo if you have some tools to predict difficult to pass the catheter to the leak. Sometimes we see a suture inside, so we cannot pass the sheath into the leak. You have or calcium or something like this have difficulties to pass the leak. You have some tips to these things?
No, I think that's often the case, that there is a suture in the middle of your leak. And if you're the wrong side of the suture, it's difficult to pass. Then if you have to get to the right side of the suture, it becomes a bit easier. I often switch to a Terumo wire at that stage to get through. And then we have to grade that up with a small 5-French catheter to go through the leak. If in fact I truly believe I'm one side of the stitch and not the other, then I can hold the catheter firmly in place with the wire that's already through the small leak, put a bigger catheter close to the leak on that wire, change over to that, and put a second wire through the other side of the suture. And so then, having removed the first wire, you can then try and pass your catheter through. So having a buddy wire, 2 wires close by, can sometimes mean you flick to the other side of the hole and therefore get a catheter through. But sometimes genuinely it is a very tortuous track. And so all catheters will have difficulty going through, and yet there is a leak. And that's when the overhang of the device is quite important, because you can be close to a leak. You have a narrow sort of gap where you go through the leak. But if you've got a big lid on it, then the lid will hopefully cover up most of the leak and reduce it.
Yeah, that's true. We usually have obtain a good 3D data set and we start to cropping in multiple planes to realize how is the direction and the trajectory of this tunnel. And sometimes these serpentinels that is very tricky to cross it, and you do not have a good angle. And there is some types of trajectory that when you cross with the liver catheter, you could make a lever and tension the prosthesis, and then it could rupture the other sutures. So we need to have a tension. In this case, decide if you go to transapical or transeptal, because most of, when it's oblique trajectory near to the septum, and you go to the liver catheter through the septums, we tension too much, and this could rupture other sutures. And I have seen several cases when a small leak have gone and extended a lot. So in these cases, we need to figure out some alternative approach.
Okay, guys, for the interest of time, I wanna kindly ask for Professor Malik to share your screen so we can have your lecture, okay? So it's our great pleasure to present Professor Iqbal Malik from Hammersmith Hospital in London, UK. And he's gonna present about PVL closure with the PLD device. Thank you, Professor.
Thank you. Can you see my screen?
Yes, it's okay.
Wonderful.
Thanks.
Okay, well, listen, again, thank you very much for the invitation. These are my conflicts of interest. I like doing structural intervention. I've worked with quite a lot of the companies, and I'm one of the co-directors of CSI. So some of this has been covered already. I think most people know that paravalvar leak closure is a palliative procedure, not a curative. It'll probably come back again. It may not be perfect, and we're not going to do it if there's infection there already. You've already seen the data that it's not uncommon, especially with mitrals. I think the TAVI rate of 20% is now old data. With the new TAVI valves, it's becoming less of an issue, and TAVI paravalvar leak closure is often quite hard to do. So I'm glad we're doing less of it. So why does it happen? Don't blame the surgeon. The surgeon may have been absolutely perfect. Blame the patient, because the patient's tissues may be calcified and weak, especially if there's been infection around. With TAVI, often there are a different set of problems that cause paravalvar leak, and the TAVI operator needs to size correctly and put it at the right height, and make sure they don't put it in something which is ridiculously calcified, because then you're likely to get leaks. So what about leak closure? Well, you've heard it's less invasive. If it fails, you can always have a redo operation, and redo surgery has quite a high risk, up to 14%. But then paravalvar leak closure actually has a significant mortality as well. These are sick patients. So how to do it? Well, most device closure is also done under general anesthetic. If you have a simple aortic leak, you can do it under local anesthetic, but then you're limiting yourself in assessing it afterwards. So almost all my cases are under general. The risks obviously are very similar in terms of stroke, bleeding. With device embolization, you have to be used to catching devices, go fishing and get them out. And whenever we're putting a device in, especially with a mechanical valve, we must always be sure we haven't made things worse by jamming the leaflets of the bileaflet valve. And then, of course, late, there's often a recurrence, and especially with device closure, hemolysis can occur. It can get worse. You're treating hemolysis, you might make it worse. And there's been one patient I've treated that went into renal failure, which is now permanent, related to the hemolysis. So my decision process is, one, should you be doing anything? And that's based on clinical, echo, and 3T criteria. In terms of clinical symptoms, even if there are no symptoms, the LV may be dilating, the PA pressure may be increasing. Of course, you may genuinely have an increase in NYHA class. And of course, hemolysis could be occurring, seen with a high reticulocyte count, and LDH elevated, the bilirubin going up. But I always tell the patients I could make it worse. In terms of imaging, we need to be sure it's something that could be closed. Is there comorbidity that means surgery? Are there lots of pseudoaneurysms? Is it too large to close? Even our biggest PLD device, and the PLD devices are the biggest on the market, may not be big enough, and it might fall out if it's too big. The second decision is, how do we do it? So aortics, mainly they are retrograde transfemoral, but you may use an apical approach if there's some problem with the retrograde approach. The mitrals are almost invariably antegrade via transeptal puncture. But again, there are some places where the apical approach would be needed. And of course, there's the approach where we could go from the aorta to a posterior leak and try and close it that way. Imaging, I think, for the mitrals, TOE with 3D guidance is absolutely essential. Fluoroscopy important. And we must speak the same language. So you've seen a little bit of this already. There's a clock face. We need to know where we're talking about. And so this is the standard aortic clock face where the left main stem is at 3 o'clock. So the way we orientate, and this is a little metric I find useful, is that orientate the echo and CT. So if you have a non-coronary sinus leak, then usually an RAO caudal is the picture that will show up. If you have a right coronary sinus leak, then usually it's an LAO cranial that will show it up on the edge of your valve. And if it's a left main leak, then of course, usually a PA shot, that's how we intubate the left main stem, is often right. But of course, it may not be in the ideal position, and the CT prediction is important. And so I tend to use the surgical view to actually decide where we're going on the clock face. So you've seen this diagram where the appendage is at 9 o'clock and the septum is at 3 o'clock, so that we all speak the same language to work out where the plug is actually going to go. And then with CT, we can plan the angle where the device will be at the edge of your mitral ring. And that is sometimes difficult to achieve, but that's what we need to try and achieve. And I always get two angles where you can see the leaflets moving very well in both views, so that at the end of the procedure, I see that the movement is still exactly the same. So the mitral clock face is obviously very, very important. If we're looking at a lateral leak, the transeptal is good. A medial leak, it could need a transapical. A transeptal can be done, but it's hard. And if we're looking at a posterior leak, then a retrograde aortic is the best approach. Most devices are like a cufflink. You have to get the catheter through, the device is compressed. And what we're trying to achieve is a device moving in and sealing the leak completely. But still, the disc on either side can trap the leaflets. If there's a residual leak, we want to get a second device in at that time. Because the problem will be, if you leave a small leak behind, you can get hemolysis. So how do you enhance success? Number one, believe in it. so that you know you want to achieve a success. If I'm half-hearted about believing it's really a good idea, I don't work as hard. And number two, having the right guidance. So leaks come in all different shapes and sizes. There is no modality that tells you exactly what the shape is. I personally have never balloon sized a leak, but I know that some people do. I use the device size that will go through the biggest sheath that will go through the leak without affecting the leaflets. And of course, if the whole valve is falling off, you can't close that with a plug. The incidence of leak closure is increasing in the UK steadily as people get more used to the technique. And I don't think that's because there's a bespoke device available. It's just that the technique has developed. And I've certainly been quite evangelical about saying it's a good idea to do this. And most surgeons now will suggest that I attempt it first, and then they can have a go afterwards if I failed. So which device do I pick? As I've said, I'm a very simple guy. So the biggest sheath that will go through, probably the biggest device that will go through that sheath is the device I'm going to actually pick. The range is vast. Most of them are in the Amplatzer plug area. And then there's the new golden PLD devices. It would be wise not to use a VSD or an ASD device in a leak. They tend to increase hemolysis significantly. If you have a leak which is absolutely tiny and no caster will go through, this AVP4 is a very delicate device, but can make a substantial difference when no other catheter will go through, because this will go through a 4 French diagnostic catheter. So if that's the only thing that goes through, then you can use that. So what about the PLD device? Well, number one, it's the only CE mark device for paravalvular leak closure, but we all have off-label use for most of our devices. It's got a very large range, and the biggest ones are the biggest devices you can actually use. It's got these 2 gold markers, so you can orientate a rectangular device in the correct orientation. And it's got some data behind it with a registry study which says that it works quite well. And I think it does. So the large portfolio has either a square or a rectangular device, and either a twist waist or actually some bulk in the waist. I tend to use the ones with the bulk. I want to fill the leak with the device as well. The commonest ones that are used are the 6mm waist device. So the waist is 6, the discs are up to 11. And for the rectangular one, the one where the 16 device, where the waist is 16 by 8 and the overhang you can see is nearly 2 centimeters. But that does require quite a big sheath to actually go through. So I'm going to show you a couple of cases to illustrate. You can see how long I've been in the game, because this gentleman had his leaking occurring in 2012. And so that's when the case was actually done. So he was breathless. He's got at least moderate leak. He's not anemic at the moment. And you can see the leaks here against the intratracheal septum, so in the non-coronary sinus. At the moment, you wouldn't be able to be sure whether there was 1 leak or 2. There might be a stitch in between. It might be a big crescent. So again, using my metric, an ARIA cranial view is probably going to be the best. Now, as you look further, I think you do see the impression that it's 2 leaks. Let's see if that will play again. So probably 2 leaks just with a stitch in between them. So the indication was symptoms, progressive dilatation. He's got a small amount of hemolysis. And so you can see the leak there again. So the idea was to do a retrograde aortic approach and put a device in. So the wire's gone across the leak. And you can now see one of the dangers and why TOE is useful. This device, which is a 9mm PLD square, is getting caught in the mitral valve apparatus. And if we did not have TOE, we may not feel it as we tug, and we could rip something. This device has then been released and moved up towards the left ventricular outflow tract. And you can see that it's going to be brought slowly upwards and then deployed. So now we've got a disc above and below, but we've still got a leak. And so this was going to need a second device. So the second crossing has now been made. A second device, slightly smaller, has been brought up. And now you can see that you can't really see very much leak. And we've got a pretty good result. So from the start to the finish, we've got a very, very nice result with a
Sorry, Professor. I'm sorry to interrupt you, because There's a question for this case. We are
Yes.
very relaxed here in the webinar. We can stop and ask,
Of course.
because it's very important. There's a question from Edgar from Rio de Janeiro. He's asking about ballooning these kinds of leaks that have stitches in order to let the sheet going through. Do you think it's reasonable, or it's risky, dangerous?
It's a very good question. So not balloon sizing, but balloon expanding the leak. So I've never done it, and I think I'd be quite nervous about doing it, because we're trying to break the stitch in between the leaks. Why is another stitch on the other side not going to break? I think I've never done it, and I must say I'd be very nervous about trying to do that. The idea of enlarging a leak to close it, I'd probably prefer to cross from the other side or use a smaller device, because maybe the idea is that if the sheath if it won't go through, maybe we haven't found the absolute vena contractor. The spray of the jet of color is making it look bigger than the leak actually is, and so using a smaller sheath and a smaller device might be worth it.
Thank you. Would you recommend the twist device, because it has this small connection ways for this kind of very tricky or septiginal leaks? And the second one is about the arterial rail in mechanical prosthesis. Some people do, some people don't do, and they think it's very dangerous. What's your opinion on this topic?
So to create a rail by going through a bileaflet valve, if that's the question, again, I would have to have a very strong reason for doing that. We might as well do a transapical procedure, which I think would be safer, because when a rail has gone through the mechanical leaflets, the tension that we're putting on them can be enormous. And so if it's becoming difficult to cross a leak, we might be putting a lot of tension on it, putting some undue force. And if one of those leaflets flies off, and I've seen that in a case report where they deliberately ballooned a mechanical leaflet, the metal flew off, and then they replaced it with a TAVI valve inside. That was an outlandish procedure. I'm amazed the patient actually survived, because the metal will fly off to God knows where as well. So again, I would say that I haven't crossed inside. Of course, if you've got a mechanical prosthesis and you're crossing outside of the ring, of course, you can create a rail, but not with a wire through a mechanical valve.
Professor Malik, I have a question. In patients with mainly hemolysis, sometimes this leak is very, very small. And even with a small sheath, sometimes I have difficult to pass through this leak. You have some tips to pass this? You have some tip to cross the leak?
So Terumo wire, I usually use an angled Terumo at that stage. I've never needed to use an angioplasty wire, but I suppose you could. But once a Terumo wire is through and snared, then if the leak is that small, then that's where a 4 French catheter, which will allow an AVP4 device to go through, and an 8mm AVP4 device might be the answer to adapt to whatever track it is, because it's a very flexible device. Unlike the other devices, it's got no strength in pullback, so you can easily pull it out. But I would suggest a Terumo wire for 4 French catheter, and then try an AVP4.
Okay, thank you.
Shall I proceed?
Yeah, yes, please go on.
Okay, good. So we've got the 2 devices in, and I've got 8-year follow-up on this gentleman. Initially, he had a bilirubin up to 25. He looked a little bit yellow with that as well, but that settled down as the device got endothelialized, and he's been absolutely fine since then with no recurrence. The second case is a little bit more esoteric. Is it a mitral case? Well, I'd call it mitral, but it's actually in the mitral curtain in between the aortic and the mitral valves. The patient had endocarditis. It pretty much destroyed his heart. The blue is the aortic valve. The yellow is the mitral valve. The red is a pseudoaneurysm. And just at the edge of the pseudoaneurysm, you can see a hole. That hole in the LVOT goes to the left atrium, creating what in effect is mitral regurgitation, but not really at the mitral curtain. And the anatomy was so difficult to understand that actually this is the only case I've had a 3D model printed, and I couldn't understand the 3D model until I'd colored it in myself, as I have for you now, to decide which structure was which. So this procedure happened about 3 months after his life-saving surgery for the AVR and MVR. He went home with none of that, but there was a weakness clearly there, and he came back 3 months later for the procedure. What I didn't treat was this, because you can see the pseudo aneurysm that he's got, which in systole compresses both coronary arteries as well. But he had absolutely no symptoms from there. It's a very, very wide mouth, and he has mechanical valves in. So there's no reason, there's no way to actually treat that. There is a recent case report where they put an appendage closure device into that pseudoaneurysm and then put a TAVI across it to hold it in. Unnecessary, I think. I don't know the clinical indication that would require that. And the pseudoaneurysm remained absolutely fine. So you can see this ridiculous leak. Really quite a sick patient with a very distorted anatomy. So I managed to cross retrogradely from the, so he has tissue valves, retrogradely from the aorta across the leak with the Lima catheter and snared so that I could then get a catheter from the vein to deploy a device. So the first device I had was with a 9 French Occlutech sheath and a 14 by 6 millimeter PLD device, where the margins are large. They're 22 and 24 millimeters, so a large amount of coverage. And I thought that may be large enough to place a device, but it wasn't. And so I had a retrograde buddy wire already available. So I used that to put a torque fuse sheath in and then put a very similar sized AVP3 device in. Now, interesting, the margins of the AVP device are significantly smaller. So 9 millimeters is a typo, but it's 18 by 19 millimeters. So it's a significantly smaller disc size compared to the waist. The waist is 14 by 5. So the two devices were interlocked. You can see the gap between them. And they were both released one after another to produce a very reasonable result. So the torrential mitral leak was reduced to mild. In fact, you can see the V wave. So the V wave pre and the V wave post are significantly different. So he had a significant improvement, went back to work as a carpenter. Sadly, only 3 weeks ago, he died of a brain hemorrhage, but he was at full-time work until the day before. So we can't save them all, but we stabilized his heart and he did very well for a few years. The next issue to deal with is the very tough intraatrial septum. And if you have a very tough septum and you're doing a mitral leak, then an RF needle or electrifying your BRK needle, which is what I do. So I use a diathermy and touch the BRK needle, and that can actually produce a puncture. You can also use CTO wires, obviously, to try and puncture, and a steerable sheath can be helpful. So what about failure? We've heard, of course, that you fail, sadly, because you can't cross the defect with a wire. Obviously, with better anatomical techniques and a steerable sheath, that's better. Or you can't cross the defect. Once you've got a wire across, it's very disheartening when you can't get a catheter across. So a mother and child approach with the smaller catheters sizing up to bigger catheters can help. And obviously, if you can get a rail, then you can really hold on tight and push hard. So if you've got a catheter through and then you can't deploy a device safely, that's even more disheartening. And I've had cases where no device would sit without jamming the leaflets of the metallic valve. And so then you have to abandon that case and say, I cannot leave it safely there because I will make the situation worse. And then finally, failure I would rate as if there's still some leak despite a device being present. I try and leave as little leak behind as possible. And if you need to use more than one device, that's okay. So when we're doing it, we have to prepare for the worst. So I think doing it in a surgical center is absolutely the right idea. And I wouldn't be dabbling. You should have maybe one person in the center doing it, not 5 people trying it. Ready for device embolization with snares, ready for angulation obstruction causing a problem even after you release it. So you have to have forceps and snares to pull it out. Wait for coronary obstruction to occur, especially with left main stem leaks. mitral leaks, you can compress the circumflex, of course, also. So this is a registry of the PLD device that was taken, and it was over 100 patients. You can see that the mitral valve and the aortic valve, most of the time, it's a crescent-shaped leak. And the common devices were usually the ones with the waste, and I tend to prefer the wasted devices in any case, as I say. So there were some adverse events. So 6 were considered related to the device. 3 patients out of that 130 odd embolized. There were some residual leaks in 2, and of course you can always get a vascular complication. And these patients are sick. So the fact that there's a 10% death rate at 1 year is no surprise. These are not well patients. So if you need to read the paper, that's from Honorato, and the summary of that was that you've got very high success rates with the device. It's a low residual leak rate, and hemolysis is not a major issue with this particular device. So in summary, I'd say allow time for the case. Don't have a go at the echo team for aortic cases because the imaging is hard. Feel free to have a go at them with the mitral cases because the imaging is very nice and really useful. The PLD is good for the larger leaks when you can have bigger sheath in. If you really have difficulty, then downscaling the device or switching to an AVP3 could be an alternative. But it really is a useful addition to the armamentarium. And with the larger phalanges it has on it, it can cover larger leaks. Thank you.
Well, this was great talk. Thank you very much for your time, for being with us. This is a great opportunity to expand our contacts and our networking with our colleagues. And I know you're out of time. You have some issues, but if you have some minutes to answer some questions, I will be
Sure.
will be very glad to. So let's go for questions from the audience first, and then from the panelists. Okay. So we have a question from Gustavo Gama from Maranhão. He's asking about aortic leak post-operative, but the patient is doing fine so far. And she has a considerable leak, which is moderate. He's asking if what's the best approach, to intervene or wait for hemolysis or for the LV getting worse? What are your recommendations in these cases?
So if we're talking about early, we're talking about 3 weeks after surgery, I'm not touching the patient if they're absolutely fine. Once they're 3 months or beyond, the stitches are well held, then I would treat that moderate plus leak early, because what are you waiting for? That moderate leak, like any water going through a hole, will make the hole larger, and eventually the left ventricle will fail. And so it will be better to plan an intervention after 3 months of surgery if there's a leak left behind. Often it's in the non-coronary sinus with aortic leaks, and the surgeon finds it difficult to stitch there. So feedback to the surgeon and plan a closure.
Okay, thank you. There's another one from Carlos Bernini, asking about, there's an issue in Brazil with this Occlutech device, to be very honest, because I have told you before, we only have the devices. We don't have the specific gear, let's say, well, the Occlutech sheets for doing this. So I have to use the Terumo sheets or Cook sheets or whatever. And I think that's a problem because they're not fit for that, or you're making some improvisation and the caliper and the sizes are bigger. So he's asking about, for example, to doing a aortic leak with a 8F or 9 French sheets, if you have used our carotid approach because of the some worries about the vascular complications in the legs, in the femorals. Okay,
so I'm a TAVI operator, so an 18-20 French sheath in the leg isn't a problem for me. And so I think so a 10 French sheath in the leg to get a big Occlutech device in, it's not the leg I'd be worried about, it's getting the sheath across the hole. And so again, I'd go back to my idea that the biggest device I'm going to put in is the biggest sheath I can get through the hole. The Occlutech sheaths are fine. The TorqueView sheaths are brilliant. So the kit is sort of interchangeable. I've I've inserted one device into another company's sheath. We all have to be a bit creative when we need to. The only thing I would say is that for an aortic leak, you need a longer sheath and obviously a device with a longer cable. At one stage, Occlutech had long cables, but short sheaths. And so that became a difficulty. But now I think that's resolved. So the lack of Occlutech sheath per se shouldn't stop me. If the French size fits, then you can use any sheath that is long enough to get through the aortic leak. And of course, the length is less of an issue with the mitral. You can use any sheath of the correct French size to get across the mitral leak and then deploy device.
Professor Malik, congrats for an excellent lecture. I would like to complete one question of mine as well. One question for Edgar also about hemolysis. You have talked about the use of ventricular septal defect devices increase the risk of hemolysis. Does it include when you have a little residual shunt or without residual shunt?
No shunt. No shunt. It's the blood going through the sieve of the device. For some reason, the ASD and VSD devices have much higher hemolysis rates. So the Amplatzer plugs and actually the PLD have much lower hemolysis rates, presumably because there's fabric inside them. So the fabric stops the hemolysis. But I think some of the VSD and ASD devices also have fabric. And so I don't fully understand why, but also the shape is wrong. The VSD will make it circular, open the hole. The ASD will make it circular, open the hole. So having an oblong device that fits is better. But I think there's no doubt in my mind that I would avoid VSD and ASD devices.
That's a question, I'm sorry. That's a question about Edgar that comes to mind about the characteristics of the PLD device that have reported exactly at this point about the reduction of the special characteristic of the device to reduce that problem.
Okay, so I think it's more the fact that it's got probably a different wire mesh to the other devices. And although I haven't looked into it in detail, the crosshairs, how small each hole is, may be part of the reason for the hemolysis. It also has fabric inside it. And I think both those features mean that less blood will go through the device. And therefore, I think that's why the hemolysis is lower.
I was going to comment that because once we had a talk with Chet Rehal from Mayo Clinic, and the reason that he uses the AVP2 or these kind of devices is that the mesh is more, they are more closed, less space between the mesh, and the wires are all I don't know the size of the mesh, but they are smaller than the mesh from the ASD or the VSD, and then you have this space gets filled quicker by the blood and thrombosis, and then less hemolysis. Then I want to open the discussion about for our panelists. I have a question from Marcelo. Please, Marcelo.
Professor Malik, you have demonstrated to us how you can have so many different anatomies of these paravalvular leaks, and some anatomies are very, very tricky. Despite advancements of cardiovascular imaging, that nowadays we can navigate in this image and also simulate some procedures, when you think that is useful to have a 3D print model of this valve and paravalvular leak to plan and simulate the case? Because sometimes here you just go to the model when you have a failure in the first tentative of the procedure. So how is your experience?
Yeah, so I must say that the case I showed was the only one I built a model for, because the anatomy was so complicated. My worry is that the tissue characteristics of the heart are very different from the plastic model. So the CT scan will give you an idea of where the leak is. I'm thinking that it's probably guessing what the track of the leak is, and therefore trying to practice implanting a device in this sort of situation is probably not real life. So the only reason I did it for my case was because there was so much going on. I couldn't really work out what was leak and what was pseudoaneurysm. and then I had to color it in, as I say. So I'm a bit stupid that way. I had to use my colored crayons to actually make it work. So I don't routinely do 3D modeling. I think I'm not sure it's proven its track worth at the moment. And in particular, because the plastic that you print on is quite hard and therefore not as forgiving as the tissues. And so how the device sits in the plastic model for paravalvar leak, I think is going to be very different from how it sits inside the heart. So I probably would, if I had failed, think about any strategy and then do a 3D print and see what else I could think about. But usually I think the failure is because of an angle of attack, not the right kit in the lab available. And actually, I've come back on a second occasion. So it's also the tiredness of the operator. So I've struggled for an hour or two. I said, look, I know where it is. I'll have a different thought the next day. I bring them back a few weeks later. We're starting from where we left off. We've already had that learning in our head from the first case. And there's no harm in that. You know, the patient can come back for a much better, safer procedure, having had more thought into it, and you felt the heart. So that's also a good way of actually doing it.
Okay, perfect. Thank you very much.
Carlos, can you would you like to make some comment or question?
Good morning, Professor Malik. It's a good pleasure to be with you in this session. I have a question related to the misalignment of the leak inside the left ventricle. Some colleagues ask us about the difficulty of put the PLD in the correct position once it's inside the left ventricle. Do you have any tips and tricks about this? What to do? We can rotate it inside the left ventricle. What do you do in this case?
So the only way to rotate it really is to deploy both discs in the left ventricle and then turn the cable. If you have one disc trapped in the sheath and one disc out, when you rotate the cable, you will unscrew the device and it'll fall off. So if you want to reorientate, a small twist of the whole sheath, if it'll allow it, that's what I first do. If that's not working, then I'll deploy both discs, so both discs are out, and then I can turn the cable to turn both discs. And when I think it's in the correct orientation, I recapture one of the discs and then pull it up.
Very good.
So if I understand, it is possible to turn together with the sheet and the cable and the device, or just you go on, you want in the ventricle, just the cable and the device.
So if you have, your sound quality is not very good, but if you have one disc already in, don't turn the cable, turn the whole sheath. But once you have both discs out, you can turn the cable, and I think never keep on rotating in the same direction. So you're going to turn the cable one way, and then if that's not working, turn the cable the other way. Because if you keep doing that, then you've unscrewed your Pepsi bottle. It's going to spray everywhere.
Very good. Wang, any comments or questions for Professor Malik?
Professor, when you use a vestibular device Occlutech with a 10 French sheath, I'm concerned about it's a big hole. You can put a 10 French sheath. It's feasible to when you feel that you're not comfortable to not pushing, not close the leak in this case, because
So
my opinion.
Are you talking about the hole in the heart or the hole in the leg?
The leak.
In the leg. Okay, so as I say, as a TAVI operator, I've got no concern. So a 10 French sheath is a small sheath for me, and so I think we should all get used to the idea.
It's not about the access. It's about the you put inside the leak a 10 French sheath. It's a big hole, the leak. So when it's safe to keep it going in this case?
So if I understand the question, it's a big leak, which is why you're using a 10 French device to put a 16, 18 millimeter wasted device in. So the hole was already big. I think the calibration of how much you push to get the sheath across comes with experience. I think we don't want to disrupt the heart. We don't want to do more. A telescope sort of method might be useful. If an Occlutech 10 French sheath is really not getting through, then you've seen in my case that a very similar size device has a much smaller torque view sheath, which might get through, and then you've still got a reasonable result. Or you could choose two smaller devices side by side with two sheaths. And so you have two wires across, put two sheaths across, and then you have a solution where you release both devices very, very close to each other. So you don't leave one device unattached to a cable, then push another device through. That's not a good idea because you may ping the other device out. Have both on the cable, and once they're both through in position and you're happy, then you can slowly unscrew each of them. So I think downsizing to smaller sheaths and having two devices is also a very good strategy.
Okay, thank you.
Very nice, very nice. You do you have to leave now?
Yeah, so I'm going to go, and mainly because actually I've got some sort of chest pain. So it's, don't worry, I'm not going to the hospital, but I'm sitting in a very strange position, and so I'm getting increasingly comfortable. So I will leave you, but it's a real pleasure to have joined you. I've enjoyed the discussion, and I think as CSI collaboration increases, if we're going to do conferences in South America, I'm very happy to shake your hand in person.
Yeah, you good, and we can catch you in Frankfurt in next June, okay?
Yeah, see you there. All the best.
So thank you very much. It was really a pleasure to be in touch, and that's it. Thank you. Have a nice weekend.
Bye-bye.
Thank you, Professor.
So let's move on with this discussion. Now we have the pleasure to do you want to present Carlos? Please, don't present. Agora é o No, because it's gonna be recorded. Yes.
Okay. Carlos is going to, from a very great friend from Salvador, Bahia.
So, desculpe. Sorry.
Max,
okay. So, Carlos, can you? Max was saying that you are very good friend from Salvador, Bahia, and it is a pleasure to receive you here. And you're going to show a very, very nice case of paravalvar leak with this device. Please, Carlos.
He's trying to share his image. Is going on.
A gente não te ouve. Mic is off.
I'm trying to share this. You see, can everybody see this?
Yes, yes. Go ahead. Thank you.
Yeah. Good morning, dear colleagues. I'm Carlos Vinícius from Salvador. I'm supposed to share with you a challenge case of paravalvar leak. First of all, I have no disclosures related to this presentation. Our patient was a 62-year-old man with hypertension, diabetes, and recent mitral valve replacement. 2 years ago, he underwent a biologic Livanova Sorin pericarbon number 31 valve on mitral position because of prolapse and ruptured roda tendinea. In the same procedure, was realized bypass surgery with Lima LAD diagonal sequential surgery. This patient was hospitalized on October 2023 with heart failure symptoms, and in this period we could see there was a closed paravalvar leak with severe mitral valve regurgitation. So this patient on exams have only NET probe NP increase, but normal renal function and no anemia. And the HG was normal in this patient also. So this patient received some medication, mainly diuretic therapy, and was discharged after 1 week. It was a low-risk patient. He went to my I saw he on consultation, and he was a very low risk patient with 1.8% of mortality at STS score and a 2.8% risk of mortality on every score, and he wasn't also frail patient. He was using aspirin because of the coronary arteries history and some medication for heart failure, as you can see. He showed me the echo realized in this hospitalization. We can see enlargement of the left atrium. Here we can see also increase on left ventricular volumes and a confirmed severe mitral regurgitation secondary to paravalvular leak. Other finds in this echo was that the biological process was had thickened leaflets, but with preserved global opening, and the leak was in a 3 to 5 hours position on 3D echo, and the vena contracta area was estimated on 0.74 centimeter square. Another thing that we can see was hyperechoic filamentar mobile images in atrial phase that was asked about suture material or vegetation in this patient. Here you can see that images. In the left side, you can see that filamentar image described in one echo. And in the right side, you can see on Doppler a big paravalvular leak, mitral paravalvular leak, as described in the last slide. So we can see also the 3D images showing us 3 o'clock paravalvular leak with Krasinski shape. Here you can see better. So this patient underwent an investigation for endocarditis, obviously, but it was ruled out after 3 sequential negative blood cultures in a PET-CT scan. We done a new CT analysis on November, and the CT analysis show us 1.6 by 4.9 centimeters leak on lateral view, and 1.1 by 0.6 centimeter on ventricular view, and confirmed the crescentic aspect of the leak and the medial position. That is very difficult to do by percutaneous approach. So this patient went to
Carlos, one minute. Let's stop here to discuss. That's very, very interesting case. I want to hear the opinions of all the guys here. First of all, Wang. Wang and Marcelo, Miglioranza, opinions, because this is a very tricky case, because this patient is class 2 heart failure and with a big leak, but he's doing good. He's not very sick. He's doing his activities with low symptoms. We know that leaks are very tricky ones to do, and we know that it's a palliative procedure. So would you go for this case because it's very tricky one, because it's kind of medial, or would you wait a little bit more to see what's going on with the patient, and if he gets worse, then we would go for intervention? And also Max can talk. Please, Marcelo.
Okay, these are very important questions, because when we look for regurgitation, valvular regurgitation, or perivalvular leak, what really matters for the follow-up of this patient is the regurgitant volume. The regurgitant volume that will overload the LV and LA, and this will develop all the symptoms of the patients in the follow-up, during the follow-up, and also the left ventricular dysfunction. And our intervention must look for this patient and indicate due to the severity of the regurgitation, and not for looking just for the complications, the repercussion. Because when we have a repercussion, it's too late. It's too late to change the outcome of this patient. So, in my opinion, if this patient have a severe regurgitation, a higher regurgitant volume, this patient will develop in the following years LV dysfunction, and we should avoid this. So we need to change the outcomes of the patients with the percutaneous perivalvular liquid closure.
Wang, please.
I agree with Marcelo. I think it's the natural history of these cases is will evolve with left ventricular dysfunction. I think it will be late to approach in this case. I think it's a good indication to close the leak right now.
Pablo, can I say something?
Yeah.
Another thing that was very important in this decision was the surgery time. Yeah, we thought that 2 years ago only it's a very small time surgery. So this patient is supposed to have more, maybe 8 years, 9 years of normal functioning of the mitral valve. So in the future, this patient could go to a transcatheter therapy of the mitral valve. So it was a point of the decision. In the other point of the decision was because the patient clearly refuse the possibility of new surgical procedure because of the insights of the surgery only 2 years ago. Yeah.
Max, what do you think of this case?
No, it's completely natural to refuse the surgery, re-surgery when you're looking at an option percutaneous. I agree with Marcelo that we have a very amount of regurgitation. A very important tool is when you use the gradient of the transvalvular flow. When you talk about peak gradient and mean gradient, that looking at it, you have an idea about the hemodynamic importance of this regurgitation. The amount of regurgitation you are going to have a problem is not exactly what you are a natural valve. You have to approach, you will have to evolve, we have to stop the evolution of the disease. And when you have problems, we exactly say, when you start the symptoms, probably you are late. So I agree with the treatment on a prematurus, not prematurus in this time.
Perfect. Okay, Carlos, thank you. Go ahead.
So decide to do the procedure. We, as Professor Malik showed, we choose the PLD Occlutech new device, new for us in Brazil. I say that because the CE mark of this product was in 2014, but here in Brazil only a few months ago. So this slide was also presented by Professor Malik, so I'll pass this. So we choose to do this procedure by interrogate approach. Although the challenging characteristic of this because of the septal location, but we in the planning of this case we choose to do a very low and posterior transeptal puncture to assess better the leak. So we can see the intra procedure images. Our dear colleague Max measured the leak with 1.1 centimeters by 0.45 centimeters. We can see the percentage aspect of the leak in the location, in the main location of this mitral valvular leak at between 3 and 6 o'clock, as you can see. So we choose the 12 by 5 device, the W rectangular device. You can see the picture that we done in the day of the case. You can see the waist, the central waist of the device, and the rectangular aspect of this. So we show everybody the procedure in the right side of this slide. In the left side, we show what we use in that day. So general anesthesia, arterial line in the right radial artery, and our main access was a 18 French hook sheet. So we done the transeptal puncture very low and inferior location with Swartz SUR1 and BRK needle. So we changed this by a Agilis sheet and cross the leak with a vertebral of the lumen. It's a black one catheter. It's very, very hydrophilic catheter, and it's go very good in this case. After that, we put our second access. It was a femoral artery 6 French access to do the snaring on descending artery, descending aortic artery. So we done a rail that was very good because it serves to improve our support to go with a 10 French delivery system through the leak. And after that, we can release the Occlutech PLD rectangular waist 12 by 5 millimeters. And we will show you the results of this. Only one point that I forgot to say, you can see a safari wiring in the left ventricle. In the same time, hydrophilic wiring that was a safe wiring that we put there, because if we need to put another plug, another PLD, we can use this wire, but it was not necessary. So we can see the left atrium hemodynamics in the left side of the slide. You can see the rouge V wave in the left atrial pressure curve. In the right side, you can see the improvement of the pressure in the left atrium post release the PLD. And here we can see the echo assessment in the superior images. You can see the 3D images of the PLD, and inferior you can see this effect in reduction of the regurgitation on Doppler. So summarizing our case, was a 62 years old male patient with low risk for a new surgery, but only 2 years after the first surgery of mitral valve replacement. So he refused to do a new conventional surgery on this valve, and presents us with heart failure symptoms. So we underwent a closer to the leak with a PLD Occlutech rectangular waist with a very good results. In the follow-up of this patient, he was discharged after 48 hours and was discharged in use of aspirin and clopidogrel, and we supposed to do a 3 months echo, and after that take off the clopidogrel of this patient. I could see this patient 15 days after the procedure, and he presents me without murmur and with no symptoms of of heart failure. So he was very good in this consultation. Thank you very much.
Okay, Carlos, great case. Thank you for sharing this case with us. Very educational. I want to stress some points of this case that I think they are very important for tips and tricks. First one, I really think it's very important to have an 18 French sheath in the groin, in the vein, so we don't have to exchange lots of sheets and wires. Then you have and the patient doesn't bleed too much, because sometimes when you have these exchanges, the patients sometimes they lose too much blood, and you have to transfuse them. And I think it's very important. You can see it on the screen, these 18 French. Then you can use the Agilis sheet, you can use the BRK sheet inside, and then exchange all that you want. The second thing that's very important is to use the Agilis sheet with a vertebral or even a JR catheter, hydrophilic, to cross the leak. This is very important. Then the third aspect is the AV rail. The AV rail for this location of leaks that are medial or posterior are very important, because you have extra support to close the leak, to cross the leak with bigger sheets. This is very important. And the fourth aspect is that when you do this rail, you don't have to lose this rail. Then you go for another sheet and another wire. You pass through it, through the leak, and then you remove this sheet and you leave two wires in the heart. The first wire is the AV rail that you just forget about it and leave them, because this is safety rail, this super safety rail, if you have to recross the leak, otherwise you lost your sheet. And then you have to insert the device into this sheet, and sometimes you lose it because you have to recross or reposition, and then you lose it. And then if you have this rail, you can just go over it, and you don't have to cross the leak again. I think these are points that are very, very useful for, and then you can do the case in 1.5 hours, 2 hours, instead of waiting 4 hours or 5 hours. I don't know if Wang wanna stress something important about the technique, or Marcelo or Max. Please feel free to open the discussion.
Okay, this question I would have done before, when we were discussing about multiple devices, not the implantation of one, but 2 or 3. What is the most appropriate technique during the deployment of these devices? Is to deploy one and then use the safety guide to go with another one and deploy, or cross with multiple guys and deploy simultaneously 2 or 3 when we need more than one device? Because sometimes I realize that our safe guide is in opposite side of the residual leak, and sometimes you do not have what to do, just deploy and then pray to the pressure close out the leak. What's your opinion?
Remember when they say in English that they say exactly, the king is dead, long life to the king. If one hole that you fix, another one appears to importance that does not appear previously. So the hole were there, but has not importance. When you fix one, the other one appears. That's a point that we have to be prepared during the procedure. And the other one is, excuse me, Ricardo, you don't have to be lazy. You have to be, you have to work, and put every catheter and wire first on the deployment, because when you have deployed one device, it's too difficult to cross again. So you deploy the wires in every hole that you have, especially when you have a cross or you have a split hole. You have to cross every with a wire, and then you perform to deliver the device at the same time, because deliver the wire is too difficult to cross again.
I think, Marcelo, my opinion, I think the first thing is which device you have to close the leak. If you have a dedicated device like Occlutech, you can use only one device because you have rectangular, you have different multiple size. So in this case, I think it's most of the case you use only one device. When you use Unplat's AVP2, you'll be prepared to use multiple devices. So have many techniques. I usually use to implant the first plug and after put a sequential plug with a rail in this case. So sometimes we see that things that you said. Sometimes you have a leak in opposite side of the leak. So when you put the second device, sometimes this device push the other device in opposite sides. So this can complete occupy the whole leak. So it covers all leak. So I think it's the main problem to me is when you have a suture inside the leak. So you have put one device in one side and the other plug in the other side. So in this case, the rail don't help you anyway. This is my opinion. So if you use multiple devices, the one thing is don't deploy the plug before you put all plugs, because you can lose it during the
you
maneuver.
can embolize it, right? Or you can embolize it, which is
it's very catastrophic. Sometimes.
I think this question is kind of difficult to answer because leaks are very tricky and they're very particular. Each case is different from the other, so you have lots of techniques and there's no right or wrong technique. You have to use many techniques as you study, as you know, to achieve what you want. So it depends on the anatomy. You see this case of Carlos is a crescentic one. It's a big hole, and then you have to go straight. One wire, one safety wire, and one plug, and one PDL. If you have lots of stitches in the middle, for example, when we are opening the ring and lots of sutures, you have to go for any, like Max said, any hole you have to go through it, and you have to use one specific small device or big device depending on the anatomy. And sometimes you have when you have the plugs, for example, the AVP, if you have a bigger hole, sometimes you have to use two sheets simultaneously, and you release the left disc of the two devices, and then you getting back with both devices and release them simultaneously. So it depends on each case. You have to study the case. Sometimes I think the tomography is good for some special and tricky anatomies because in the beginning you have to understand the 3D, and we as interventionalists don't know how to analyze a multiplanar CT because we don't have the eyes. And then when you get used to see it, and then after that you don't need it. You don't need it anymore. But in the beginning, I really recommend that.
Another important thing is about the toolbox. You have to be complete toolbox. We have to do with the snare. We have a lot of different wires, different catheters, because we are going to appear different situations during the procedure. So you have to have a complete toolbox previously to the procedure. I think that we have to start to resume our discussion, and it's important about the different opportunities that the PDL has about different designs. With the rectangular one, when you have a very huge, a large, and a crescent the defect, with and without the Y, the neck or the Ys. That's important about, we have to, if you have stretch during that, you can use a device with a twist device, because you are going to use the proximal and the distal disc and not the central one, the central part. It's important about the task force, the force that has the device, and the important that not enlargement force in the center disc. That is important, that we have the twist and you have a waist. You have a rectangular, you have a quadrangular. So different situations you can use the different things. If you have a not twist, not match during the entire hole, use the Y, the wide one. See, if you have interruption during the hole, you use the twist. That is important. Different situation, different design. Perhaps we are going to start. We're finished. We are on time. Marcelo, can you start for your last positions?
So, as I have seen during all the session, evaluate, plan, and perform the procedure of paravalvar could be very tricky. So we need to perform a multidisciplinary approach with different images, modalities, evaluations, and be prepared to the worst scenario. So it's not easy sometimes, and if you have done 10 and we think that you have a lot of experience, you could be disappointed, because every procedure is completely different. And also thinking in different approaches and different assess, not just anterograde or retrograde, not just crossing the interatrial septum, but also thinking apical. Nowadays, we try to avoid apical approach, but sometimes it's needed.
Thank you, Marcelo, for your time. I think it was very good discussion. Carlos, your final considerations.
Although most leaks are in mechanical prosthesis, our case was a leaking on a biological prosthesis. So as we are thinking in TAVR cases, we think in this patient, we have to think in lifetime management of this cases. So 2 years after the index surgery, it's a small time. So we think we have always to think about this. The input the patient in discussion of the management of these cases. And now we have a specific device, so we can choose between the 19 types of of the Occlutech PLD and choose the better for our patient, in this case of leak. And it's very important to rule out endocarditis in this patient. I think it's very interesting points to discuss. So it was a pleasure to be here with everybody, and it's my comments. Thank you.
Thank you, Carlos. Thank you very much for your case. Wang, please. Your mic is off. Mic is off.
Well, first of all, I think this leak is very challenging because of different mechanisms, different anatomies, different location. So don't think the leak is the same thing. I think it's a multidisciplinary approach, like Marcelo said, is very important. Study the images, look at the CT, look at the echo images, and you have enough tools and different techniques. Not all the leak is treated equally in these cases. So I think it's every leak is they have a challenge. So be prepared to treat this leak.
One important thing is that leak is not exactly a problem that starts at the time of the surgery, but it's important to have a 3D, a transesophageal echo during the procedure, during the surgery, to take a picture how is the final results. And then we exactly without any problem, we can have complications even years ago, especially for endocarditis infection, and corticoid therapies also can develop a paravalvular leak that does not appear earlier. I would like to highlight the final message to Pablo and invite you to remember on April 28th, we are going to have our anniversary webinar with Horst Siever. Thank you very much for your attention. The final words with Pablo.
Well, I think it was a very educational webinar. I really want to thank you guys. Thank you, Marcelo. Thank you, Carlos. Thank you, Wang, for being here, for your time, for your knowledge. And I want to thank especially all the team of For Valves, Pedro, Andiara, Tuca, for all the support for doing this one. And as well, all the guys that were working a lot, all the community, all the groups, always exchanging good information for the good of our patients. And last but not least, I want to thank you very much, all the people of CSI, Inga Sieverts, Professor Sieverts, Shakil Qureshi, Sir Shakil Qureshi, and all the guys from Come For You, Arthur Toledo, who's Brazilian and working there, Micaela Tomazova, Chao Tran, and all the guys. I'm sorry if I lose someone because there are so many people to thank. I think we are starting a new era here to get more in touch with people outside and to increase our networking. You have to stay tuned in the groups because there are lots of good things coming, and it's gonna be a real pleasure to see all the people from Latin America in Frankfurt, June this year. If you can send your cases for the Cat Lab Cafe. You can send your case or your abstracts for discussion. It's a very open and wide environment where everyone can stand up and say your opinions, your cases, your thoughts, and so everyone can learn from each other. It's the principle of CSI and it's the principle of For Valves. So I think it matches perfectly, and then we can grow and in the end doing the best for our patients. Okay, so thank you very much for your time. Thank you for everyone who has been in touch with us. And I think we want to see all of you in April, because Professor Siebert will go and show you and show us a very, very, very nice presentation on bioabsorbable devices for the future of the septal diseases, and would be thrilling. Thank you very much, and see you next month. Bye-bye.
Hi, thank you.